I think we might save the question until the next speakers, Sean Orenstein. I think Sean is a professor of surgery in Oregon University. He's going to tell us about how to choose the right mesh, and then we can have a discussion on these two talk or questions, and then go for the case discussion. Welcome, Sean.
Hello, I'd like to thank you for the invitation to speak at this esteemed conference. Here's my disclosure slide. And while these disclosures are relevant, I've made an effort to remove as many brand names as possible from the slide deck, though I will be discussing specific meshes throughout my talk. I've talked in the past about the basic science of mesh and what happens upon implantation of mesh prosthetics. Things like chronic inflammation. And the thing with inflammation is that it doesn't matter what prosthetic material you put in there, all meshes induce some degree of inflammation, regardless of the material. But what about that foreign body reaction, which is a really key element when you talk about the tissue response, where you get these foreign body giant cells or coalescence of macrophages that really highlight something that is very foreign in an entity to the body, and it can induce a massive inflammatory and other response to that material. Even things that we don't implant in the groin, but just to discuss material science, is things like PTFE, but also things we do implant in the groin like polyester, which these materials can induce a significant foreign body reaction. Well, what about some of the newer monofilament polyesters, things like ProGrip and Versatex? These can also induce significant foreign body giant cell responses as well as inflammation. And also fibrosis, that is, what is the amount, the quantity, as well as the characteristic of the fibrotic and scar response to those materials. Things like polyester, as well as different weights of polypropylene, going from heavyweight microporous to medium weight to ultra lightweight macroporous meshes. All of these meshes induce some degree of inflammation, scarring, and foreign body response, though there are varying degrees of effects from these meshes. So if we move on and just specifically talk about mesh weight or density with regards to groin meshes, it's important to at least take a step back and look at the physiology of the abdominal wall versus groin, because there is definitely a paradigm shift when we talk about how we decide on the density of meshes for these different areas. And the biggest difference is for abdominal wall hernias, we strive for defect closure. That is, we're getting fascial reapproximation and then supporting that with our mesh. Whereas with groin hernias, we do not close the defect. Therefore, the vast majorities are bridge repairs. And I want to exclude for a moment plication of the inguinal floor for blown out inguinal floors for open repairs. But if we talk about just the defect and the lack of ability to close those defects, this is going to steer us into more of a heavyweight mode of meshes just because of the sheer fact we can't close those defects. Additionally, fixation plays somewhat of a role, whereas with the abdominal wall, while we have been striving to reduce the amount of fixation, we have a greater ability to fixate. We have multiple types and methods of fixation and locations, whereas with the groin, there really is a limited ability to fixate because of the critical neuro and vascular structures in the groin. Just to briefly review different numbers from when we talk about mesh weight density, we use a lot of lightweight in the groin. Those are usually less than 50 grams per meter square, whereas the heavyweights are typically greater than 90 grams per meter square with medium weights in between there. I want to highlight a few papers here which I think are really key to understanding where we are with regards to the weight density of meshes in the groin. Some of these are meta-analyses. One is a large retrospective study and one is a prospective study using ultra lightweight mesh. And while initially intended to go through these study by study, given abbreviated time, I'm just going to summarize these studies for you. And interestingly, there are some differences with regards to laparoscopic placement of mesh versus open inguinal hernia repair. And for lap inguinals, the studies were showing that there actually was an increased risk of hernia recurrence with the use of lightweight meshes, and especially for direct hernias, and such that using a lightweight mesh increased the risk of hernia recurrence more than 2 times and more than 7 times for direct hernias as far as a relative risk. Well, how about when we talk about pain, foreign body sensation, as well as quality of life metrics? Well, this is where the studies were interesting in that lightweight and heavyweight were equivalent. That is, heavyweight did not induce greater foreign body response or reduce quality of life. One of the studies showed that ultra lightweight mesh, specifically Ultra Pro, was used in this study, greatly increased the risk of hernia recurrence and was recommended against to use in the groin. So bottom line is all these studies point to a consideration for greater use of heavyweight mesh in the groin for the reasons I've laid out, as well as the physiology of most of these being bridge repairs. For open repairs, it's a little bit different, but a lot of overlap in that there was no difference in recurrence or severe chronic pain, although one study did show that lightweight mesh did reduce the amount of foreign body sensation as well as any chronic pain. But again, most studies do demonstrate similarities with regards to long-term outcomes between these two meshes. So for me, for my algorithm, for most indirect, small to medium, and even some larger sizes, as well as tiny directs or tiny miscellaneous hernias such as peripubic hernias, I favor a lightweight mesh for these. Now, if we switch to larger hernias or most direct hernias, where the physiology is a little bit different, that is, with a direct hernia, these hernia defects are propped open, whereas a lot of indirect hernias are more like a valve where they're kind of shut down. And so the smaller indirects can be accommodated lightweight mesh, but for directs, large indirects, as well as multi-recurrent defects, I'm going to favor a heavyweight mesh for those. And putting these all together, kind of showing the sort of descriptive sizes of defects and types, this was my previous algorithm. However, this has changed somewhat in the last year as there's been a more mid-weight mesh is being produced. And I use a lot of contoured mesh using 3D Max for my MIS repairs, whether it be lap or robotic. And having mid-weight mesh has really shifted me toward the use of that for a lot of different repairs that I did favor lightweight meshes, and in fact some heavyweight. So for me now, for small to medium-sized direct or multi-recurrent meshes, I have shifted those over to a mid-weight 3D Max in the groin, as well as some medium to large indirect hernias. Certainly there's some overlap in these categories. I do tailor it on a case-by-case basis, and I've even had it on people with bilateral hernias where I put one weight on one side, such as a light or mid-weight on one side, and I've used, say, a heavyweight on the other side because they had different hernias on each side. How about self-gripping mesh, things like ProGrip? Surgeons love to use this because of the ease of placing it in there and limited need for fixation. One large retrospective, meta-analysis of randomized controlled studies showed that there really was no difference between the use of self-gripping mesh and standard flat mesh for open repairs. While there was a shorter operative time using the self-gripping mesh, there really was no added benefit to the use of ProGrip for open repairs. How about for laparoscopic repairs using self-gripping mesh? And similar to other studies, basically found no difference in recurrence and no difference in chronic pain, although the study took it out only to 13 months. So most studies basically show that self-gripping mesh is safe to use. I think this is a surgeon preference. The one thing I will say is that I do strongly believe that you need some form of fixation, especially for direct defects, regardless of using a self-gripping mesh or a non-self-gripping mesh. We don't want that mesh to eventrate into that hernia defect. So medial fixation, I think, is key for all medial defects, regardless of the type of mesh used. How about biologic or bioresorbable meshes? Well, there's limited data on this. For biologics, there actually are a handful of studies, even some randomized control studies. However, I think these are poorly powered studies. Out of the 4 randomized studies that I looked at, less than 200 patients in each group, and follow-up was quite low. Even one study as low as 3 months follow-up, which might be showing some short-term wound issues, is certainly not long enough to evaluate long-term efficacy. So most studies show that biologic meshes are safe and effective with somewhat similar outcomes, although one study showed an increased recurrence with small intestine submucosa. The bottom line is that larger and more long-term follow-up studies are necessary to advocate for the use of biologic mesh in general. How about bioresorbable meshes like poly-4-hydroxybutyrate? This study used Phasix. This study did carry it out to 30 months and didn't see any recurrences. There was one patient with chronic pain that resolved at the 2-year mark, and one seroma and hematoma, and basically showed this was a pilot study, which they acknowledged. They said it's safe and feasible, but larger and longer term studies are certainly needed before widespread adoption. Now to move on to a public service announcement. So apologies ahead of time for triggering some people with some of my upcoming slides. But the first thing to talk about is split or double mesh, the use of laparoscopic and robotic repairs. This is kind of an older traditional laparoscopic method of doing lap inguinals, where the surgeon would cut open a mesh and split it around the tail, with tails going around the cord, sort of akin to an open Lichtenstein, but in the preperineal plane done laparoscopically. Many times this was covered up by a second mesh to cover up the entire myopectineal orifice, again with the deeper mesh wrapped around the cord. And the problem with this is that not only are there 2 layers of mesh here now, but these meshes, because the way they wrap around the cord, they tend to induce a significant amount of fibrosis, which with the combination of fibrosis and mesh contraction, that can lead to compression around the cord, which can lead to chronic pain, especially testicular pain. And these pictures are from a patient I just did last week that had this done. And as you can see from those bottom pictures, that severe scarring and fibrosis from the mesh to the vas deferens there. And while I was able to free up the mesh, there's certainly, the procedure is not without risk and can carry some morbidity. And while the patient is improved, there still is recovery to go, as I did have to get close to the vas deferens just to free up, to make the vas deferens more mobile. So it's not without risk. Well, how about mesh plugs and 3-dimensional meshes like Prolene hernia system? And I would emphatically say, please, let's just stop with mesh plugs. Here's a picture of one with both direct and indirect plugs. I've seen people with more than 3 plugs in multiple orifices in their groin. And taking these out for chronic pain is not a benign procedure. You can really tear up the groin and the inguinal floor, whether it be from open or minimally invasive techniques to get rid of these. So it can carry morbidity. Also, 3-dimensional structures like the Prolene hernia system. And I don't want to confuse 3-dimensional mesh like the PHS with things like 3D Max. 3D Max is just a contoured flat sheet, is not the same thing as a 3-dimensional structure that spans multiple tissue planes like the PHS and plugs. So the PHS is a bilaminar mesh, and the problem with PHS is you've occupied 2 different tissue planes, both anterior and posterior tissue planes have been burned with this, as well as with a tubular structure that spans the mesh. And this can also result in significant chronic pain. So interestingly, when you look at the data, it actually shows similar recurrence in chronic pain from this. However, I think that underrepresents the true outcomes of using plugs and PHS. And as somebody that removes these from time to time for chronic pain as a result of these, I would emphatically say that these should not be used because A, they do not add any benefit to the patient, but they have some potential harm, whether it be severe scarring, migration, mesh erosion. And I've put in here the guidelines for the international guidelines from Hernia Surge, and they also with strong recommendations to avoid mesh plugs or Prolene hernia system and the like. So to summarize, for when it comes to mesh weight density for MIS repairs, the interesting thing is that heavyweight mesh does not add any additional risk of pain or foreign body sensation. A lightweight mesh increases the risk of hernia recurrence, especially for direct hernias. So basically, really consider a greater use of heavyweight and now some of the newer midweight meshes for minimally invasive repairs. For open repairs, there is equivalency between heavyweight and lightweight. I do so much of my repairs in a minimally invasive fashion that most of my open repairs are for large inguinal-scrotal, so I'm tending to favor a heavyweight for these, but lightweight, a mesh for small defects in open repairs, I think is very reasonable for patients. And then this is, again, one final look at my algorithm for light and medium weight with a lot of overlap, and then heavyweight for any large, as well as most directs and multi-recurrent hernias. And then to summarize some of the last little bits I talked about, self-gripping meshes, while they plus or minus shorter operative time, there was really no found to be a significant benefit compared to flat or contoured mesh with regards to hernia recurrence or chronic pain. Split double mesh for MIS. This is old school and unnecessary and can lead to downstream problems. Mesh plugs, PHS, just please stop. No, it's unnecessary to place these in human beings these days. For the vast majority of inguinal repairs. And finally, biologic or bioresorbable mesh. There's really minimal data, but it's shown to be safe, but there's insufficient data for widespread use. And so I think we need to find the right time and place for biologic and resorbable meshes, perhaps for small or when there's concern for infection, when we don't want to place a permanent prosthetic, if we can't do primary tissue repair. With that, I'd like to end, and again, I want to thank you for your time. Thinking back to better days when we're able to hang out, looking forward to future days where we can truly be with each other and spend time. And I'm wishing the best for all my colleagues around the globe, especially in India and in other places which are getting hit hard right now from the pandemic. Hope everybody comes out of this okay, and look forward to seeing you all in the future. Thank you very much.
Thank you, Sean. I just realized David Waddell there looked so young at that time. I think we had about a minute or two before we start the case history. Is there any question from the panel to our past two speakers? It's really truly knowing that there's different way to skin a cat, we call them, or skin a hernia, may we say.
So I had a question for Dr. Orenstein. What is the minimum size of mesh you would recommend in a tall patient with a direct defect of around 2.5 centimeter?
Well, thank you for that question. A lot of people have talked about using a minimum of a 12 by 15 centimeter mesh. And this size is sort of variable because, yes, flat sheets are hand trimmed, but some meshes come pre-shaped, pre-sized. So again, as I said in my talk, I use a lot of 3D Max. I use a large as my smallest mesh. I don't think I've ever placed a medium-sized mesh, and they don't make a small. But I really have used a lot more extra large in the last couple of years to really get a full coverage of the whole myopectineal orifice. So it depends on their body size and their pelvic size. It goes from large to extra large, or roughly 10 to 12 centimeters by 15 to 17 centimeters to really get good wide coverage, especially like you suggested, a direct defect. Want to get good wide coverage, and that mesh is usually going past the midline for each side. So a lot of times there's overlap if I'm doing a bilateral.
Thank you.